So welcome back guys. So in this particular session we'll be talking about the non-communicable disease. In the previous sessions we have already talked about the communicable diseases, right? So in this particular session we'll be talking about the non-communicable disease, right? In the non-communicable disease, if we talk about, then basically guys, if we are talking about non-communicable disease, these are the chronic diseases, right? They will be persisting in the community for a very long period of time. Okay, so basically these are also known as chronic diseases. You might call them as chronic diseases, right? And if you remember the previous sessions, right, we have talked about the trends also, right? In the basically in the descriptive epidemiology, we had a talk about the trends, right? So basically the long-term trends we used to call them as secular trends, right? So these particular diseases are actually following the secular trends. Secular trend means there are some diseases which will be decreasing in the community over a very long period of time, over decades, and there are some diseases which are actually increasing in the community for a very long period of time or over decades, right? So these are some of the diseases which are actually, these incidences of the incidences of these diseases are actually increasing in the community over decades, right? For an example, I'm talking about which kind of non-communicable disease. For example, obesity, right? Obesity is leading to so many kind of disease, right? If we talk about diabetes, hypertension, right? If we talk about the rheumatic heart disease incidences, they are actually increasing in the society over decades, right? So we are going to talk about in this particular session mainly about these kind of diseases which are actually coming in the community over decades at a very high rate, right? So basically the non-communicable disease, these are the chronic diseases. They will be persisting in the community for a very long period of time, right? So usually we are seeing that they are associated with the long duration. They are associated with the long duration, and slowly they are progressing. Right? Now if we talk about, there are two types of non-communicable diseases over a very broad picture. If I will take a very broad picture over here, we can see that there could be two types over here, right? One type could be the infectious, right? Infectious non-communicable disease. For an example, rheumatic heart disease is the infectious disease example over here, and other one are the non-infectious disease. Okay, we are not talking about some kind of infectious agent like we were talking about in the communicable disease. Here I am talking about a non-communicable disease, right? So non-infectious, right? So basically most of the diseases in the non-communicable disease, we are talking about non-infectious, but some disease might be there, they could be infectious as well. For example, I will talk about the rheumatic heart disease, rheumatic fever. You must have heard about it so many times, right, in so many subjects. So basically what we have heard over there, what is the etiological agent? That is bacteria, right? That was group A beta hemolytic streptococci bacteria, right? So we will talk about that. So that is the infectious cause over here if we talk about the non-infectious, right? If we talk about the non-infectious, right? Okay. Now here are some diseases guys which we are going to talk about in this particular session. So basically in this particular session we are going to talk about the non-communicable disease, in which four main types are there. What are these four main types? One is the cardiovascular disease, other one is the cancer, okay, other one is the chronic respiratory diseases, and the diabetes, right? These are the non-infectious diseases mostly, okay, and other types could be there. For an example, we might talk about the hypertension or dyslipidemia, obesity, right, metabolic syndrome. There are so many other types could be there, right? So the list is long over here. Rheumatoid arthritis could be there, okay, cerebrovascular diseases could be there, osteopenia, osteoporosis, which are usually associated with the elderly population, right? Degenerative disc disease, okay, sarcopenia, depression, cognitive impairment, neurodegenerative diseases, or other kind of diseases might also be coming over here. These are all non-communicable disease. The diseases which are not associated with any kind of infectious agent will be termed as your non-communicable disease. Okay, so for basic broad category, if we talk about, there could be infectious, there could be non-infectious. Mostly non-communicable disease are the non-infectious, right? That is kind of a summary of this. Now let's move on to further, one by one in these particular diseases, and let's talk about some of the important points, some of the salient points as far as this non-communicable disease are concerned, which will be very helpful in solving our MCQs, right? Okay, so guys, I'm gonna talk about very first one, that is the cerebrovascular disease, right? That is the basically the coronary artery disease. We are seeing that over decades the cases, the incidence of this coronary artery disease in the hospitals, in the community, basically they are increasing day by day, right? So it could be so many factors leading to this particular thing, right? Atherosclerosis is there, high cholesterol levels, major lifestyle changes, and the obesity factor is there, cigarette smoking might be there, alcohol consumption might be there. There are so many multiple factors could be there which are actually leading to the coronary artery disease or cardiovascular incidents in the community. But the fact is they are increasing in the community over decades, right? And we have seen that. So this is it is following one particular trend. If I'm asking you, it is following one particular trend, what would be the answer? Which kind of trend I'm talking about? Yes, that is the secular trend, right? Secular trends are those trends which are actually long-term trends, right? Okay, so we had to talk about that in the time fluctuation section in the descriptive epidemiology, right? For details, please go through that section. Okay, guys. So now let's move on to very important one. That is the very first one I'm going to talk about. That is the coronary artery disease incidence, right? CAD I'm writing. That is your coronary artery diseases, or you might call them as cardiovascular event. Okay, cardiovascular disease as well. Okay, fine. If we talk about the coronary artery disease, right, I'm not going to talk about the medical things over here, medicine things over here. Okay, that you will study in detail in your medicine part. Okay, but here I'm going to talk about the most important points as far as community level is concerned, right? So over here we shall talk about, in the coronary artery disease, how to prevent this coronary artery disease. So we are having a prevention strategy, right? So we are having over here, that is the prevention strategy. In the prevention strategy, we are talking about the levels of prevention. We are talking about the levels of prevention. What levels I'm going to talk about? We have talked about that, for an example, primordial prevention, primary level of prevention, secondary level of prevention, right? Remember that? So same thing we're going to apply over here in the coronary artery disease, right? So let's look over here. In the prevention strategy, guys, we are having some subcategory. So one is the population strategy. Okay, population strategy. Other one is the high risk strategy. High risk strategy. Okay, and the other one which we shall talk about over here, that is the secondary prevention. Okay, everything you will be understanding. Okay, just give me some time over here. So if we talk about the population strategy over here, right, now I'm gonna take first one over here, that is the population strategy, right? Population strategy. In the population strategy, we shall talk about two things over here, right? In the population strategy, we shall talk about two things over here. One is the primordial level of prevention, and other one is the primary level of prevention, right? One is the primordial level of prevention, other one is the primary level, or you might say that as second specific protection, right? Primordial level of prevention and specific protection. Primary level of prevention, if I will talk about particularly, then it will come in the high risk strategy. But for now, let me talk about the population strategy, in which we are talking about, right? We are going to talk about first one, that is the primordial level of prevention. Primordial, right? Primordial level of prevention. In the primordial level of prevention, we shall talk about the health promotion. If you remember my previous sessions in the level of prevention, in the concept of health and disease, we have talked about that primordial level of prevention, primary and secondary level of prevention, what are these things. In the primordial level of prevention, we don't want to allow even the risk factor inside our body. So what we are actually doing, what we are trying to do, basically we are trying to promote our health. Okay, how we can actually promote our health? By doing the various kind of exercises, by doing the yoga, right? And if we are actually creating the awareness regarding the yoga in the community, or creating the awareness regarding the exercise in the community, okay, so obviously the chances or the incidences of the coronary artery disease in the community will be reducing drastically, right? So that will be our success in that, at that point of time. So that is the point of introducing this primordial level of prevention at the population strategy. Okay, so coronary artery disease is there, right? How we can prevent it? Okay, as a community people, okay, as a community level physician, okay, how we can prevent this particular coronary artery disease in the community? We are going to talk about those steps. The first one I am talking about, that is the population strategy. In this population strategy, we are going to talk about the primordial level of prevention. How you can do the primordial level of prevention in the community? By promoting the health of the people, right? By creating the awareness of that particular thing, the importance of doing the yoga, importance of doing the physical exercise in the community. If you are able to do that, then obviously primordial level prevention will be success. So over here we are going to talk about, in the primordial level of prevention, basically what important point we are doing? Health promotion. Okay, in the health promotion, if I'm doing, so what kind of point I can add over here? For example, you are creating the awareness about the physical activity in the community, right? So physical activity in children, okay, if the physical activity will be increasing in the children, adolescent, right, physical activity in children and adolescent, right, if that point would be there, then obviously if they will be starting the exercise, yoga, all of these things, all of these physical activities in their routine at this point of age, right, so obviously when they will be growing older, right, the incidences of having this coronary artery disease will be reducing, obviously it will be reducing, right. Okay, then we shall talk about in this particular thing, if some particular people, they are having the obesity factor. So obesity is a very important risk factor for causing the coronary artery disease. So we should promote the health basically in this case. So we will be actually motivating them to reduce their weight basically. So weight control factor is very, very important over here, right. If some population, if some people, adolescents, they will be actually, this period is very, very crucial, adolescent period. So many of the adolescent, they are getting this bad habit that they start smoking or they start the consumption of the alcohol and all. So if by any chance, okay, we are reducing these incidents, that they are reducing the consumption of alcohol or the smoking, so that is also our primordial level of prevention, right. So in this particular case, basically we will be actually reducing the chances of coronary artery disease in the coming future. So basically stop smoking and alcohol, right, these kind of steps also will be coming in the primordial level of prevention, right. Okay, next point over here which we shall talk about, that is, so we have talked about the primordial level of prevention. Now next one, in the population level only, in the population strategy only, we are going to talk about the specific protection, right. We are going to talk about the specific protection. In the specific protection, basically we are going to talk about the diet. We are going to talk about the dietary recommendation. Once we are done with the primordial level of prevention, then we are coming to a specific protection. We want to control the diet of the people, right, because lifestyle changes are very, very important. So if we will be able to do some of the lifestyle changes in the particular people, then obviously we will be getting the success in this case, right. So how we can actually modify that? So we are actually having the criteria for the diet. For an example, what should be the fat intake, what should be the cholesterol intake, what should be the protein intake, right, what should be the carbohydrates intake. So all of these things we have actually decided, and we will try to communicate with our people that if you will be consuming this particular constituents of your diet, right, then obviously the incidence of the coronary artery disease will be reducing, right. So obviously we will talk about that. So this is the specific protection. Specifically we are focusing on the diet of the people, right. So that is the thing. So here in this case we shall talk about the diet component. For an example, so dietary recommendation is there, okay. In the dietary recommendation, we are going to talk about, for an example, look over here, what should be the fat intake in the community, what should be the fat intake, right, what should be the salt intake, right, and what should be the cholesterol in the people, I mean the cholesterol consumption, dietary cholesterol, right, what should be the total level of HDL in the community, right, what should be the total cholesterol in the community, right. So these factors could be very, very crucial if we will be able to if we will be able to communicate with our people about this particular thing. So if you talk about the fat intake, for an example, it should be less than 20% of their diet. It should be less than 20%. If you talk about the salt, basically it should be less than 5 gram per day, because obviously if they are increasing their salt intake in their diet, it might lead to the hypertension might lead to the coronary artery disease incidents, okay, and directly it might be leading to the coronary artery disease as well. If you talk about the cholesterol is very, very important factor, because cholesterol might lead to the development of atherosclerosis, that might actually reduce the blood flow to the coronary artery disease, and coronary artery basically the blood flow might be compromised, and then it might lead to the coronary artery disease in itself, right. So dietary cholesterol, if we talk about, they are saying that it should be lesser than 100 milligram per 1000 kilocalorie per day, okay. So they can actually take the cholesterol obviously, but obviously less than 100 mg per 1000 kilocalorie per day. If we talk about the total HDL level, then they are saying that it should be more than 40 milligram per deciliter. Right, in a very layman language, HDL is the high density lipoprotein. Basically, it is kind of a good factor for us, right? For the it is kind of a good factor for the body. Okay, on the other side, we are having the low density lipoprotein, that is the LDL. That is not good, obviously, right? Okay. Total cholesterol should be around less than 220 milligram per deciliter. Okay. Once they have asked us what should be the total cholesterol HDL ratio. Okay, what should be the total cholesterol HDL ratio to prevent the incidences of coronary artery disease? So in that case, if they are asking us that what should be the total HDL cholesterol ratio, right, or total cholesterol HDL ratio. Okay, let me just rub this one. Total cholesterol HDL ratio, they had asked once. Total cholesterol HDL ratio, right? Then it should not be more than 3.5, right? It should be less than 3.5 only. So it should be less than 3.5, right? That was direct MCQ. So please remember that. So total cholesterol level should be less than 3.5. So once we have talked about the population strategy, now we are going to talk about the primary level of prevention. It means I'm going to talk about the high risk strategy, right? So population strategy we have talked about. Okay, I told you 3 components. Remember, I told you 3 components in the prevention strategy. We have talked about the population strategy. Now I'm going to talk about the high risk strategy, and then after that we'll be talking about the secondary level of prevention. So now let's move on to the high risk strategy. Okay, now let's move on to the B, right? High risk strategy. Population we have talked about earlier. High risk strategy. If we talk about high risk strategy, in this particular case, we are going to talk about the primary level of prevention, right? So basically it talks about the primary level of prevention. How we can do the primary level of prevention? We are going to talk about the primary level of prevention. Primary level of prevention. In the primary level of prevention, usually we are saying that, if we are having some suspect in the community, okay, we'll try to treat that community, right? Or if there is some risk factors present over there, for example, it could be the obesity, it could be the smoking, it could be any other risk factors also, it could be the consumption of alcohol. Okay, if we'll try to reduce those risk factor in the community, then it will be the primary level of prevention. So primary level of prevention talks about basically, the reducing, for example, smoking incidences or alcohol consumption, right? Or you are treating the suspects which could be present over there in the community, right? So those kind of people, if you are finding out and you are doing the intervention over there, that is the primary level of prevention. Basically the risk factor is present in the community and you are trying to bring down that risk factor and you are trying to stop this risk factor to convert into the disease, right, in future. So that is the primary level of prevention. Then we are coming over to the next one, that is the secondary level of prevention directly, right? Secondary prevention. Secondary level of prevention. In the secondary level of prevention, secondary level of prevention is talking about basically, we have talked about that in the concept of health and disease chapter as well, that here in this case we are gonna do the screening, we are gonna do the perform the diagnostic modalities in the community basically, and we are gonna treat the patients, right? So in the secondary level of prevention, if we are doing some kind of intervention for the betterment of the health of the person, for example, now there are the incidences of coronary artery disease in the community, right? So you are going to treat those particular cases. For example, you are doing the angiography. Why you are doing the angiography? To find the blockage, right? If you are doing the blockage, you are doing the intervention. This is which level of prevention? Secondary level of prevention, right? You are performing some kind of investigation. You are performing the CPKMB test, you are performing the troponin I test, you are performing the cardiac biomarkers test, right? In these cases, to find out that whether it is angina, whether it is coronary artery disease, whether it is myocardial infarction, something like that, right? So in these kind of cases, you are doing the investigation. If you are doing the investigation, this is the secondary level of prevention, right? You are doing the angioplasty for the patient, this is the secondary level of prevention, right? You are performing some kind of intervention, you are performing angiography, right? As we have talked about earlier, this is the secondary level of prevention. So secondary level of prevention talks about basically the intervention. Intervention in terms of basically it could be any kind of procedure, it could be any kind of procedure, or it could be some kind of diagnostic modality. It could be some kind of diagnostic modality, right? It could be treatment of the person as such, right? You are prescribing some of the drugs for an example, right? For example, you are giving the statins to the patient, you are giving some kind of let's say loading dose you are giving to the patient in the case of myocardial infarction disease, right? So these kind of intervention if you are doing in your patient, this is the secondary level of prevention, right? Okay, fine. Okay, so we have talked about the strategies, population strategy, we have talked about the high risk strategy, and we have talked about the secondary level of prevention. Okay, that is the prevention strategy for the coronary artery disease in itself, right? If we talk about now, some of the trials are present in the community, right? Some of the trials are present by us in the community basically, and they were happened in the past, right? So to find out that what are the cases which can lead to the incidence of heart disease, right? And these kind of trials, because they are historical, basically they might be asked in the MCQs further, and they have been tested in the past as well in our MCQs. So over here, this is very important to discuss about them as well. So one very important one, which is very, very potential for your MCQs as well, that is the Framingham heart study, right? You must have heard about that in the cohort study as well. I have told you that Framingham heart study was one of the longest study, and that was studied on basically the heart disease patients, right? That the risk factor is present over there, whether it will lead to the coronary artery disease incidences or not, right? So it was a long study, it was for about 20-year study, and it was a cohort study, right? So it was one of the longest cohort study, right? So that might come as an example. So over here, I am just taking the trials over here, right, which have been performed in the past and all, right? Okay, so if you talk about the trials, basically here, first trial which I am going to talk about, that is the Framingham heart study. Framingham heart study. Okay, Framingham heart study, basically this is the longest cohort study. Longest cohort study, right? Studied for about 20 years. Okay, very important. Second point over here is that it talks about the association of risk factor to the disease, right? What was the cohort study? Guys, it was a prospective study. It was the cause to the effect study, right? The risk factor is present in the community, okay, and whether it will cause the disease or not. So this is a long process, this is an expensive process, right? We need to wait over here. So it was a 20 years long study, basically Framingham heart study, very, very commonly tested, right? So Framingham heart study, okay, you can't forget this one. Okay, so over here it talks about the association between, right, association between the risk factor and the disease. Okay, risk factor and the disease. What kind of risk factor we might talk about? There could be many risk factors, smoking, obesity, and many other risk factors could be there, right? And disease which I am not talking about, that is the coronary artery disease basically, or the cardiovascular events, right? Okay, next study which I am going to talk about over here, that is the MONICA, right? Yes, that is the MONICA, right? MONICA, basically what is MONICA first of all, right? MONICA, it is basically, okay, what is the full form of the MONICA first of all? Let me just tell that as well. So MONICA, basically this is not the name, okay, this is the name of one particular study, one particular trial basically, okay, this is the abbreviation of that. So basically it is the multinational, right, monitoring of trends and determinants in cardiovascular diseases, right? Yes, it is a long name, okay, and that's why we have actually abbreviated this as MONICA, right? So MONICA actually talks about the trends monitoring in the heart diseases. So basically MONICA is telling us about trends and determinants monitoring in cardiovascular events, or in heart diseases simply, or in heart diseases, right? Okay, now third one which I'm going to talk about over here, that is the Oslo study, Oslo Heart Study, right? Oslo Heart Study says that Oslo Heart Study, okay? Oslo Heart Study talks about that whether there is some association between the smoking and the coronary artery disease events or the cardiovascular event. So it talks about the association between the smoking and the coronary artery disease event or coronary artery vascular events, right? Okay. So it talks about, okay, studies association with smoking, again that is a risk factor, leading to heart disease or not. Okay. Then we are having fourth study. These are actually the trials, basically how the question might come. Either they will ask you this kind of trial is talking about what. Either this could be the question, right? For example, Oslo Heart Study talking about what. 4 options will be provided. Otherwise, they might ask you which of the following trials is not included among the coronary artery disease events. So then 4 events would be given, 3 events would be the right answer, and 4th one you need to odd one out, you need to pick that out, right? So basically we have talked about the Framingham Heart Study, that is a very, very important one, and I'm sure you will not forget this. Then the Monica is there, Oslo Heart Study is there. One more trial which I'm going to talk about, that is the Stanford 3 community trial. Okay, Stanford 3 community trial. In this particular trial, basically they said that it studies the effect of your health education. Okay, you know that what are the pros and cons, what are the, basically there are no pros actually, there are only cons of the coronary artery disease. So basically you will be educating your community, right, educating your population about the coronary artery disease, right, what not to do or what to do. Okay, these kind of things. So what is the impact of your health education on the people? Okay, and after your health education to the community, how many incidences actually they are increasing or they are decreasing or they are same. So that kind of study is actually coming under the category of Stanford 3 community trial, where you are giving the health education and what is the impact of that health education on the coronary artery disease events, right? So basically it studies the effect of your health education, okay, on cardiovascular events, right? So if the cardiovascular events are actually decreasing after your health education, then obviously that was your success, right? So that talks about the Stanford 3 community trial, right? Next trial which we are going to talk about over here, that is the MR-FIT, right? So what is MR-FIT? Again, this is the abbreviation of multiple risk factor intervention trial. Okay, and basically it studies about the multiple factor associated with it, right? It studies the multiple factors. What multiple factors? For an example, obesity, hypertension, right, cholesterol levels, diabetes, whether they will be leading to the coronary artery disease or not, right? So multiple factors which might lead to the coronary artery disease, it will be studying about those factors, right? So it actually studies the multiple factors. So MR-FIT is talking about, it is actually studying the multiple factors. It could be the smoking, it could be the obesity, it could be the diabetes, it could be the any other cause, right? And that is leading to the coronary artery disease events, right? That basically studies under the MR-FIT, right? So studies multiple factors, like it could be smoking, obesity, diabetes mellitus, cholesterol levels, and all of these things, right? DM, etc., right? Association with cardiovascular events, right? Cardiovascular events. Okay, guys. Fine. So once we have talked about this, right, now we shall move on to the next one. So we have talked about the coronary artery disease. We have talked about the prevention categories, right? How we can prevent it. We have talked about the primordial level of prevention, population strategy, then the high risk strategy, and then we have talked about the secondary level of prevention. Then we had to talk about some of the trials which are very important related to the coronary artery disease, which have been happened in the past, which are the studies which happened in the past and frequently tested in your MCQs as well, right? Now I'm going to talk about one more important non-communicable disease, that is hypertension, right? So now let's talk about the hypertension, guys. So second topic which I'm going to take over here, that is the hypertension, right? So second topic, let's talk about over here, that is the HTN which is a very famous abbreviation over here. That is your hypertension, right? The details of the hypertension will be discussed in your medicine section, but over here I'm going to talk about the as a community physician what you need to know about the hypertension, right? Obviously, first of all, you need to know about the classification. We'll talk about that, but before that, this is basically very important particular non-communicable disease, and over decades we are seeing that incidences of the hypertension are increasing in the community tremendously, right? And we know that hypertension and diabetes are a very good friend of each other. So we know that if some patient is there who is diabetic in front of you, right, make sure you are actually taking the history of hypertension as well, because most of the times we are seeing that if the hypertensive patient is there, he is diabetic also, he or she is diabetic also, and if the diabetic patient is there, he or she might be the hypertensive also, right? So this is very common association we have actually found out, right? So hypertension, basically this is a very major risk factor for causing the coronary artery disease as well, right? So this is major risk factor, right? Earlier we have talked about coronary artery disease also, so it is one of the major risk factor for the coronary artery disease and the cardiovascular events, right? And that's why we should be actually controlling the hypertension, okay, in the patients, right? That is very, very crucial for us, right? Other thing is, what is the prevalence in the males and the females? If we talk about the prevalence, guys, in the males and the females, right? So in the males and in the females, in the males we have seen that it is around 15%, and in the females we have talked about that is around 11%, right? So in the males it is around 15% and in the females it is around 11%, right? And according to the European Society of the Hypertension, right, they have talked about in the June 2018 they came up with this particular classification. In the June 2018 they came up with this classification, right? And what they said in this classification, guys, okay, I hope you are able to see now. So in this classification, very simple classification, okay, so over the decade we have seen many classification, but this is the one which is the very latest one which I have took over here, that is the June 2018. They talked about this particular one. So basically, guys, in this one, optimal optimal BP of the patient should be, we know that very frequently, very frequently we are checking the BP of the patient in the hospital settings and all. We know that it should be between 120 and 80, okay, even the non-medical people knows that, right? Okay, then comes the normal BP. Okay, so usually we are generally saying, okay, it is normal only and it is hypertensive, okay, very in the layman language. But obviously you should know this particular classification. So for next time when you are visiting your wards, when you are visiting the hospital, okay, when you are visiting any clinic, okay, in any department, in every department, the first job of us is basically taking the blood pressure of the patient, right? Taking the blood pressure of the patient. So over here we should be actually talking to ourselves that yes, it is high normal, or it is first grade of hypertension, second grade of hypertension. We should be talking like that, right? So that is the proper way of diagnosing the hypertension. That is the proper way of classifying the hypertension basically in the patients, right? From the next time, make sure you do it after reading this classification, right? So let's talk about this classification, guys. Optimal is less than 120, and that is the systolic, and less than 80 is the diastolic. Now normal is 120 to 129, guys. 120 to 129 is the systolic one and 80 to 84 is the diastolic one. If that is the case, then this is normal, okay. High normal 130 to 139, okay, or 85 to 89, okay, or you might remember it, 130 to 140 is the systolic one and 85 to 90 is the diastolic one. If it is coming, then this is the systolic and diastolic, that is the basically high normal. Okay, so there is optimal, then there is normal, then there is high normal, then there is grade 1 hypertension. Grade 1 140 to 160 and 90 to 100, that is the systolic and diastolic respectively. Over here in the systolic, it is grade 2 if it is 160 to 180 or 160 to 179, and diastolic 100 to 110. Grade 3 more than 180 and more than 110, right? Systolic, diastolic respectively. And isolated one, isolated systolic hypertension means diastolic is normal. You are seeing that is the 90 only, right? That is the 90 only. But here, if it is more than 140 systolic one, then that is the isolated systolic hypertension. Means systolic is raised over here, but the diastolic is not much, right? So over here, that is the isolated systolic hypertension, right? If they are asking you any kind of question related to hypertension, for example, they are giving you the values that this is the systolic over diastolic BP. For example, they are telling you then that it is 150 over 100 millimeter of mercury, any kind of patient, right? over 3 readings. That is also very important, guys. For an example, you are in a white coat, you visited your patient, right? And over there, the patient came to see you with any other kind of problem, right? For example, he was having the abdominal pain, but you found out that this patient is having the 150 by 100 millimeter of mercury. That is the BP of the patient. Obviously, as I said that first job is to take the vitals of the patient. Okay, doesn't matter which kind of disease or which kind of symptoms he or she is coming to you, right? He or she is coming with. So over here we'll be taking the BP. So, first reading whichever we will be actually getting, okay, we will not consider that. At least we will be taking the 3 readings to diagnose the hypertension. That is also very important, okay? And I'm sure you must have studied this in the medicine classes as well. So over here the point is, if they're asking you the question, right, that the temperature, that the BP of the patient is coming like that, okay, so in these kind of cases we are talking about this particular classification. So according to this classification you need to answer that particular question. For example, if I am saying 150 by 100 millimeter of mercury, they gave the answer, they gave the readings. So they are asking you what grade of hypertension we are talking about in this one. So guys, here we shall say that 150 by 100 I am talking about. So 150 will be coming in this category. Okay, 150 will be coming in this category, and if I am talking about the BP as 100, right, so we'll consider that category. Okay, this category. So 150 by 100, so it will be considered as the grade 1 hypertension, right? So like that you need to consider your answer. Okay, fine guys. Now once we have talked about this particular classification, then one more thing we need to talk about, that is the rule of halves. Rule of halves in the hypertension category. So what is the rule of halves, guys? Over here you are seeing that this particular kind of diagram over here, right? That could be scary, but let me tell you, it's very easy. Rule of halves, basically we are talking about in this case that in this rule of halves we are talking about that how many people are getting diagnosed with hypertension. If they are diagnosed with hypertension, how many people are getting the treatment? If they are getting the treatment, how many people out of them are getting the adequate treatment? So basically rule of halves is actually talking about the half, rule of half. It is a rule of half or rule of halves. So basically it is telling that in the community, this is the community, right? This is the community. In this particular community, only 50% of cases are diagnosed. 50% of the cases are undiagnosed. We are not knowing to them. Many of the times, patient will be coming to you and they will be having the high readings of BP. Even multiple times. You took the BP of this patient, okay, with regular interval of time. You take the 3 readings of this particular gentleman BP, okay, and every time the BP is, systolic BP is over 150. Okay, and they are saying I'm not taking any kind of medication also, and first time you are telling me that my BP is raised. This is the undiagnosed case of hypertension. So many times it is coming, these kind of cases are coming to our hospital. These kind of cases we are seeing usually very commonly. So these are undiagnosed cases of hypertension. That's why hypertension is a very important disease, and that it is a very major risk factor for causing the coronary artery disease and many other kind of disease, diabetes and all of those things. So basically the charting of the BP, or we can say the reading of the BP should be actually done from the childhood period of time only, because many of the times if in the childhood phase, if in the adolescent phase or in the children phase, if we are finding out that BP of this particular child is raised, then most likely further also this particular child will be having the raised BP in the coming life, right? If the particular child is hypertensive, then most likely this child will remain hypertensive in the coming period. So that's why we need to do the BP charting in the children age group and the adolescent age group in a regular period of time, so that we can find out these kind of cases earlier, right? That is the importance of doing that. So rule of halves is talking about that this is the community, 50% of the cases will be diagnosed only and 50% of the cases will remain undiagnosed. Out of these 50% of the community who are getting diagnosed, 50% of the community will be getting, out of this 50% will be getting the treatment. 50% will not be getting the treatment, right? And in this 50% of category who are getting the treatment, only 50% will be getting the adequate treatment. So I am saying that, very simply I am saying that, this is the community. Out of this community, right, 50% of the cases are diagnosed, 50% of the cases are undiagnosed. Out of these 50% of the cases who are diagnosed, only 50% are getting the treatment. And out of these 50% who are getting the treatment, only 50% are getting the adequate treatment, right? And we are able to follow up them. right? So basically this is the rule of half. We are actually talking about this much community, then 50% are remain undiagnosed, then 50% of getting the treatment, 50% of getting the adequate treatment. So basically we are actually doing the half of this one. So this is called as the rule of half simply. And rule of half basically we are talking about in which particular kind of non-communicable disease, that is the hypertension. I hope you have understood now what is the rule of halves, right? Once you have studied the rule of halves, okay, how this diagram can be asked, okay, and they might be asked what this particular diagram denotes. So this particular diagram is denoting the rule of halves in the hypertension. How this particular big box, this is the whole community. This particular big box is actually telling us about the whole community, right? And these red color people are actually, red color area is actually telling us that these percent of cases are remaining undiagnosed in the community, right? Then if you will be doing the half of it, then these persons are the hypertensive, okay? And if you will be narrowing it down further, then these percent cases are only who are getting diagnosed with the hypertension. Among these diagnosed, okay, this much people only, they are getting the treatment, and among this much only these many people are there with the yellow color who are getting the adequate treatment, right? So this is basically what is this particular case? Basically they are talking about the rule of halves, okay, rule of halves in hypertension. So very important guys. Again guys, let's just revise that what was the rule of halves. So rule of halves is actually telling us about, in the hypertension, it is telling us about three things I told you, that only 50% of the cases are diagnosed in the community. 50% cases of hypertension are diagnosed in the community, right? Diagnosed in the community. Second point is, among those 50%, right, among those 50% hypertension cases, right, only 50% are getting treated, and among those 50%, only among those patients only 50% are getting adequate treatment. 50% are getting adequate treatment, right? So I hope you have understood it very clearly. Adequate treatment, right? So that is the rule of halves in a very simple language, right? Okay, once we have talked about that, how we can prevent the hypertension. So there are two kinds of measures. One is the primary level of prevention, other one is the secondary level of prevention. So let me talk about the prevention also over here itself. So guys, in the prevention we shall talk about the primary level of prevention, and the secondary prevention. Primary prevention and secondary prevention, right? Simply, let's not complicate it. In the primary prevention we are saying that try to do the lifestyle modification, right? Regular BP charting should be there, healthy diet should be there, okay, all of these measures should be taken over here. So in this particular case we are talking about the regular exercises, right, regular diet, and the lifestyle modification. So these kind of things, lifestyle modification, so these kind of things we are talking about, lifestyle modification, these kind of things we are talking about in the primary level of primary prevention. In the secondary prevention, try to diagnose the hypertensive cases early diagnosis, and try to treat them as well. Early diagnosis and treatment, I mean, that's why BP charting is very important. Blood pressure charting should be done from the adolescent period of time only, right? So because if the patient will be hypertensive, child is hypertensive, most probable this child in the coming life he or she will remain hypertensive, right? If he or she is hypertensive, most probably in the coming life he or she might be hypertensive only, right? So that's how we can actually plan the treatment if we will be finding out it earlier in the community, right? Okay guys, once we have talked about the hypertension, now I'm gonna talk about one more important factor. Okay, you can say one more very important risk factor that might lead to the diabetes, hypertension, coronary artery disease events, and many of these kind of events, right? Non-communicable disease, right? Okay guys, so now I'm taking actually, that is obesity. Yes, obesity, that is very common in our community, isn't it? So in the obesity, if we talk about, we are having the indicators, right? We are having the indicators, and in which we are talking about many important things, right? Okay, so in the obesity, basically we will be talking about the indicators. Okay, we'll be talking about the indicators, but before that, let me talk about some of the important things over here, right? What is this over here? You know, this is the assessment of obesity. How you are assessing the obesity? Basically on the basis of body weight. All of you must have heard about the BMI, that is the body mass index, right? Body mass index, you know, according to the Quetelet index, they are saying that it is kg per meter square. Very commonly we know that it is the weight divided by square of the height in meters, right? So weight in kg and height in meters, right? So kg per meter square, that is very commonly telling us about the body mass index. Now here this table is actually telling us about the categories, right? And this is very important, you know, that less than 18.5, if the BMI is coming out to be less than 18.5, we are consider them as underweight, right? And this is the having the obviously low chances of comorbidities. 18.5 to 24.99, that is quite a normal range, right? So here the risk of comorbidities are average, and this is the normal range of the BMI, right? Third category is the if they are more than 25, right? If the people in the community are having BMI more than 25, then obviously they will be coming in the category of overweight, right? Less than 18.5 underweight, more than 25 overweight. Now from 25 to 30 or 25 to 29.9, right, this category will be called as the pre-obese. This category will be called as pre-obese. Obviously if they are pre-obese, the morbidity chances are increasing in these cases. Now obese class 1 tells us about 30 to 35 or 30 to 34.9, moderate comorbidity. Obese class 2, it is 35 to 39.99, that is the severe category, and obese class 3, that is more than 40 and having the very severe, you know, these kind of people who are having BMI more than 40, right? Here the comorbidities risk factor will be very high, right? Okay guys, second one, you know, this is the Quetelet index. BMI has been calculated according to the Quetelet index, very commonly asked. Then second one, you know, some more important index we might be having, that is the one is the ponderal index. Ponderal index is actually telling us about the ratio of height. Here we are considering the height in centimeter. In the Quetelet index in the BMI, we have considered the height in the meters, that was kg per meter square. Here we are talking about the height in centimeter. So height in centimeter divided by cubic root of body weight, that is in kg, right? What is the Broca's index? If you will be you know, whatever height is there in centimeter, if you will be subtracting it from 100, right, or whatever height you are having, for example it is 175 centimeter, you will be subtracting it 100 from it, right? You will be getting the proper weight which you should be getting, that is the Broca's index. For example, here in this case you will be getting 75, so your weight should be 75 kgs as per your height, right? So that is telling us about the Broca's, that is telling us about this particular thing, that is the Broca's index. Then other one is the Lorentz formula. Lorentz formula tells us about height minus 100, that is the Broca's index, minus height minus 150, that is in height in centimeter, by 2 for women if the age group, if the gender is woman, or if it is men, then divided by 4. So that is telling us about what? That is telling us about the Lorentz formula, right? Then other one is the Corpulence index. Corpulence index is actual weight divided by desirable weight. That will tell us about the Corpulence index, and it should not exceed 1.2, otherwise there is a major comorbidity risk factor, right? Okay guys, should not exceed 1.2. okay, right? So now once we have talked about this particular assessment of obesity, right, these factors, right, now we shall talk about some of the important indicators over here. What are the important indicators, right? What are the important indicators? Let me talk about them. Let me talk about them over here, right? So indicators, we are going to talk about them over here. The very first one which I am going to take over here, that is your skin fold thickness. That is your skin fold thickness. Yes, you must have heard this in your pediatric section as well. Skin fold thickness, right? In the skin fold thickness, we are actually measuring it using one important instrument over here, that is the Harpenden caliper. Okay, so it is measured using Harpenden caliper. Okay, what you are talking about, man? What is Harpenden caliper? This is the Harpenden caliper. Okay, here, okay, Harpenden caliper. Okay, here what they are saying basically, what they are doing basically, at the triceps level they are actually measuring the skin fold thickness, and this instrument which you are seeing right now, this is the Harpenden caliper, and that's how we are measuring it. Here we are getting the reading in this particular screen, right? Understood? So this is the Harpenden caliper, and that's how they are actually checking the skin fold thickness. Okay, why we are checking the skin fold thickness? To obviously to know the obesity, right? Either the person is obese or not. So measured using Harpenden caliper, I showed you how the Harpenden caliper is actually looking, right? Second point over here is, at what particular site we are checking the skin fold thickness, at what site. It's not that you are actually checking it at the abdomen over here. It's not like that. Okay, we are having proper 4 sites over here, and one of the site I showed you over here itself, that is the tricep site. Okay, so we are having 4 sites. So what are these 4 sites? Okay, so let's talk about them as well. 4 sites are present over there, and the 4 sites are like, the first one is the you shall check it in the subscapular area, right? Many athletes are present over there in the different sports. Okay, they are actually their doctor are actually checking the skin fold thickness, because it is very important for their fitness part, right? So that's why they are actually checking their skin fold thickness in a regular interval of time with this particular instrument, that is the Harpenden caliper, right? So subscapular area might be checked, right? Then you might actually check the suprailiac area, right? That is this particular region, suprailiac area. So suprailiac area might be checked, right? These sites actually might be asked. So third one is your biceps area. So that is the mid biceps, and in the image which I have showed you, that is the mid triceps area. Fourth one could be the mid triceps area, right? So these are the 4 sites where the skin fold thickness might be assessed, right? Next point over here is that if you will be including these 4 measurements, right? If you are including these 4 measurements at these 4 areas, you have checked the skin fold thickness with the help of Harpenden caliper. If you are doing the sum of all 4 measurements, it should not be more than sum of all 4 measurements should not be more than, for the males and females it is different. For the males and females it is different, right? If it is more than 50 in males and more than 40 in females, it will be considered as obesity. Okay, so that is the significance of using this Harpenden caliper. That is the significance of taking the skin fold thickness. If it is coming sum of all areas, if it is coming more than 50 and in males and more than 40 in females, then it will be considered as your obesity, right? Okay, so I will try to one correction over here. Okay, I just wrote upside over there. So basically in the males it should be more than 40, and in the female should be more than 50, right? That will be considered as this one, right? Okay, so over here we have talked about the significance of skin fold thickness. Next point over here is that what about the waist circumference? So first point over there I have talked about the skin fold thickness. Second point which I am going to take over here, that is the waist circumference. Okay, in the waist circumference we are talking about that, if it is more than 90 in the males and more than 80 in the females, then this category more than 90 in the males and more than 80 in the females, then it will be considered as obesity. It will be considered as obesity, right? Waist hip ratio, if you talk about, then our next component. So over here it should have been the B actually, right? It should have been the B, and C if you talk about, that is the waist hip ratio, right? Waist hip ratio So in the waist hip ratio we are talking about that in the males and in the females, right? In the males it should not be more than 1 and in the females it should not be more than 0.85, right? So more than 1 and more than 0.85 we talk about, if that is a criteria, if that value is coming, then obviously they will be considered as obesity, right? These people will be considered as obese. Two very important terms very frequently tested in the MCQs, that what is morbid obesity and what is super morbid obesity. So what is morbid obesity and what is super morbid obesity? Morbid obesity. Okay, what is morbid obesity and what is super morbid obesity? Morbid obesity is telling you about the BMI only. So BMI, if it is more than 40, then it will be considered as morbid obesity, and BMI if it is more than 50, then obviously drastic situation, that is your super morbid obesity.